Good morning, everyone. My name is Tommy Scheckman. I am a pediatrician in primary care in Palm Beach County. I'm also the former president of the Florida chapter of the American Academy of Pediatrics, as well as a medical consultant for the Palm Beach County School District in their ESE program. This morning, we're going to talk about the benefits and the strategies to incorporate mental health, behavioral health into the primary care pediatric office. I a long time ago recognized that almost every time I walked into an exam room, whether it was for an ear infection, for gastroenteritis, for headaches, that after determining whether or not there was a significant physical medical problem, most of what I was dealing with was the psychosocial elements of care, both for the child as well as the family. And so over the past several decades, I started incorporating self-teaching and learning how to take care of behavioral health, mental health issues for my patients. And it has become a huge component of our current practice. So this morning, what we're going to try to do is demonstrate these objectives, which is first to recognize that primary care is a very important integral part of managing mental health. We're going to go ahead and demonstrate the advantages of co-locating mental health professionals and primary care services within the same location, or at least very close to one another. We're going to describe our current practice model of how we have accomplished that, and then provide you with the strategic initiatives that you can take back to your own practices so that you can start seeing and managing children who have behavioral mental health issues. Everyone in this room recognizes that we are being inundated with issues of mental health, of problems that our kids are facing every day, the stressors that they must deal with on a daily basis. Those stressors are seen and manifested in our media and in our lives. Everything, as these slides point out, all headlines that we see are our true reality. We cannot escape the fact that mental health issues have become an integral part of what we do as pediatricians. Our role as advocates for children is to stand up and to provide the support these children need. When we look at mental health in the United States, we recognize that 1 out of 5 children meet the diagnostic criteria for a mental health or substance abuse disorder. But only 1/5 of those children actually receive treatment, and most families, when starting treatment, half of them stop and terminate care, usually because there's poor access, because of transportation, and often the shame of being engaged in mental health therapeutic services. Another close to 16% of children don't meet the diagnostic criteria, but have mental health issues that we must face. 67% of our children have experienced trauma. 23% of every child in primary care could be diagnosed with PTSD, and almost half of adults who have mental health illness present before the age of 14. So it is critical as pediatricians that we are alert and looking for this. We should be just as cognitive of potential mental health problems as we are for a child walking into our office with meningitis. It is important and imperative that these children get services and treatment and help early. We know, everyone in this room, most of you at least, and when I talk to my colleagues, are very uncomfortable about treating and recognizing and screening for mental health. Why? It's because we are uncomfortable ourselves. As a recent survey of all primary care physicians, not just pediatricians, but internal medicine family practice point out. But we also are afraid that we don't have the resources. If we recognize, ask the question, and we get the answer that we're hoping not to get, that the child acknowledges that he or she may be depressed, where do we seek help? Where do we seek support? And so, yes, there are limited resources. We need better resources, but you as a primary care physician should be able to start learning so that you can provide those direct services that are needed for your patients. What is happening here in Florida? It is amazing to me, and it's very scary actually, that 53% of children here in Florida grow up in poverty. At least 37% of children by age 5 have suffered at least one ACE, one adverse childhood experience. And then the comment that I was referring to before about appropriate screening, only 20% of children receive screening tools, and that can be anywhere from your ages and stages to doing a Vanderbilt to doing a SCARED, which is a screening for anxiety, multiple different screening tools that we have available. But when over the last several years talking to pediatricians, most pediatricians don't want to open up that Pandora's box, but we need to. It's our obligation as professionals caring for children. And then the other factor here in Florida, only 2% of children who need early intervention, whether it's for developmental delay, autism, other mental health issues, receive the proper care and involvement of experts that they truly do need. So one of the things I mentioned early on was that I am a medical consultant for the ESE program here in Palm Beach County. And the numbers that you see here on the slide are but truly are alarming. For most of you, you know what hospital homebound is, and in hospital homebound, remember in its early stages, it was meant to help take care of children who had chronic illness or were undergoing chemotherapy. They were relegated to living in the hospital, maybe at home, and to provide education that they need. Now, often schools, because they sometimes don't know how to manage that child with a behavioral issue, emotional outbursts, often tell parents, just go ahead and sign the child up for hospital homebound. And what they're truly trying to do, to be quite frank, is they're trying to get that child so it's no longer a problem for that principal of the school to get them out of their school. And so they request of us as pediatricians to sign hospital homebound papers. And you need to think before you do that is whether or not this child's best situation is to be at home. Children need to be in school, we all know that, but there's also that social component and why it's so important to be there. Plus there's that third party objective observer to try to understand what's going on. So if the problem happens to be in the household or the child has issues with social anxiety, we're only feeding it by enabling that child to stay at home to receive hospital homebound. And one of the interesting statistics here in Palm Beach County is that almost 30% of cause or reasons for hospital homebound is related to anxiety, maybe depression, but mostly anxiety disorders. And the last thing is like falling off a bicycle. You need to get back on that bicycle. If the child has anxiety, we need to get them back to school. We need a re-entry plan to figure out how to get them back in. But to give hospital homebound permission for a year just serves no one any purpose. The other thing that I just want to point out with these statistics is the alarming increase throughout the state of Florida of Baker Acts. For those who are not familiar with Baker Acts in Florida is the involuntary hospitalization of children or adults who may be assumed to be a threat to themselves or to others. But what we're seeing, and there are many reasons for it, and we can certainly have that discussion when the talk is over because we could spend 2 hours just on this one topic, is that here in Palm Beach County alone, is that we're seeing that from year to year, from the school year 2017-2018 to this past school year, we've seen an increase in the number of Baker Acts coming out of the school system of 166%. 200% is in elementary school alone. Why, I ask, does a 6-year-old need to be Baker Acted? So those are questions we need to think of, and the trauma that we are inflicting upon these children further by isolating them, separating them away from their parents, their comfort zone, and taking them and putting them into a strange facility for 48 to 72 hours. again, why think about mental health in your private practice or in any primary care practice? First and foremost, it is the first place that often mental health can and should be identified, along with developmental problems. We need to recognize that. We need to be cognizant of it. I had a parent just last night who came in with a 16-year-old who's had issues for the past 10 years, school issues, anxiety issues, focus issues. And after discussion, it was a new patient to our practice. The thing the mom said to me was, "Oh my goodness, I wish I was here 10 years ago." She recognized that and of course then there's the self-guilt that we try to assuage, but the fact is, as pediatricians, we need to pick up on it, recognize it, manage it, okay? We are not doing any service for just telling our parents they should go somewhere else to seek help, but we need to insist on it. No different than if the child has high fever and we tell them they need to make the child comfortable with providing, acetaminophen. So again, it's important. Our parents want this. They need this. We've stated it is really important to recognize that mental health, developmental issues are underdiagnosed or diagnosed late. This obviously then ends up in delaying treatment, which then ends up with much poorer outcomes. Important, again, that we recognize, identify things early so that the children can get the support and help they need in a timely fashion. And again, when we look at it epidemiologically, we look at healthcare costs, delaying recognition, diagnosis is only going to cost not only the individual child, the individual family, but it's going to cost us as a society a lot more money, because the fact is that obviously as problems go undiagnosed, untreated, it ends up resulting in more issues later on to not only the family and to the child, but to the society as a whole. There's a number of studies out there that are demonstrating that co-locating psychological services, and again, yes, our practice, which we're going to talk about in a little bit more detail, has a psychologist within our office, but just having a psychologist that you can work with, who's down the street, close by, who you can collaborate, have conversation with, I think that's a first step and it's important. And it's important to, once again, recognize that primary care physicians write the majority of psychotropic medications. It's not psychiatrists. So again, something that is important for all of us to become familiar with and comfortable. Why should the child with anxiety, ADHD, depression, mood dysregulation disorders, why should they come and why do they want to come into our offices to get the care they need? When we talk to these patients, the thing that they appreciate when they come into our office, and again, studies have shown this with multiple different offices, they feel that it's a sense of comfort and confidence. They know you, they know your staff. So the stigma of having to recognize that your child may have a mental health illness or a developmental issue becomes a little less foreboding, and they are able to deal with it, and they trust you. You are their pediatrician, so they've also recognized that. It's the convenience, certainly, and certainly you can approach it from a family-focused treatment perspective. One afternoon, I had this 17-year-old young woman walk into my office for a follow-up med check, and I noticed a tattoo that was on her ankle. I asked her, what's that tattoo? What's that chemical symbol stand for? And who in this audience might know what that stands for? You're right. It's the chemical symbol for sertraline. And I asked her, why did you put that on your ankle? And she said, Dr. Sheckman, sertraline saved my life, and I have you to thank for that. So again, it's always, it's the most important thing. We always care about what our patients and what we need to do for our patients. But it is rewarding, and it's something that you're going to see over and over again, the appreciation from patients for what we do for them when it comes to helping them with their anxiety, school issues, social issues. So at this point, with the slide of our staff from last Halloween, I'm going to bring up our behavioral health clinical coordinator, Paola Herrera, who's going to walk you through the process that we do within our own office of when and how we manage new patients and established patients with mental or health or developmental issues. Paola?
Thank you, Dr. Shetman. So this is our pediatric partner office. I think one of our main goals in our practice is just have fun and be a supported group for our patients and their families. Have a behavioral health department is not about only one person. It's take a whole group of people working for our patients, for our families. So I would like to introduce to you how we make this happen at Pediatric Partners. Behavioral Health Department has a lead pediatrician that is Dr. Tommy Shetman. More pediatricians that are involved with our families and they take care of them. In-house psychologists and a social worker. We also have a group of triage nurses that help us to screen the case and to establish what the patient needs in our office. Myself, that I'm the behavioral health clinical coordinator, I'm in charge of have all the services in-house for those patients. A case management coordinator, and of course our front desk and medical assistant. It is very important that we understand that when you have an office, everybody's important. But when you have behavioral health in your practice, everybody has to be in the same page. So our all staff is always be well trained on how we can accommodate those patients. For example, we're having a 4-year-old who is on the spectrum and is coming to the office and is very overwhelmed by the whole people that is in the waiting room or the TVs. So our front desk people are well trained in how to recognize, checking the patient, immediately call one of our medical assistants and accommodate the patient in our sensory room. So the patient can be more comfortable and can wait for his provider. Also, we use another kind of accommodation that I'm gonna show to you in a minute, but it is important that everybody understand why those patients have to be accommodated. This is our behavioral health team, and I'm gonna introduce now how we approach those patients to our practice. So the first line is the patient called to the office, or the providers, our pediatrician, nurse practitioner, refer the patient to our behavioral health department. So after that phone call, our call center or our providers just create a patient case to our behavioral health department, and that patient case goes to me, that I'm the behavioral health clinical coordinator, or go to our triage nurses. In that call, we do something that we call screen the case. We ask the families or we ask the patient what is the problem in the moment, so we can figure it out at what time the patient has to be seen, when the patient has to be seen, and who can see the patient. I'm going to give you a simple example. If we're receiving a phone call from a family that is very concerned because the child is not doing well in school, is at 3 years old, biting other students, running around, running in the parking lot and is not safe, mom very frustrated, the family is not sleeping well because the child is very hyper. That's a family that is being affected for that situation in that moment. That's a patient that has to be seen as soon as we can. We put the patient in the early morning in our sensory room, so we have the time to observe the patient in the room, sit down with the parents and talk to the parents about how is the situation. If we're having a phone call or a referral from a patient that is saying, hey, has diagnosis of ADHD since long time ago, and I would like to reevaluate my ADHD because I'm having a hard time to concentrate, I'm in college, that's a different case. So we can set up something in the late afternoon, and that patient doesn't have to be seen the next day. So that phone call helped us to establish what is the emergency of the case and how we can approach this. After my call or the triage nurse call, we set up a consultation with the lead pediatrician. The consultation could be, or one of our pediatricians, that appointment could be 45 minutes, 90 minutes, okay? It depends of the case. And after we establish that, it is important that we have to establish in that appointment what is the next step, what we're going to do, who are we seeing, that we need to refer the patient to a psychologist, that we need to talk with our psychologist in office. This family needs some help from our social worker. This family need another resources. What kind of evaluation we have to do, that we assign one of those psychologist assessments through Chavez, that we have to do a CARS-2 assessment in our office. So we plan and we set up what we need to do. We coordinate the service in-house, and we also help with the referrals if they need a referral. If they need a speech therapy, they need occupational therapy, they need physical therapy. After that, we set up a follow-up appointment with our lead pediatrician or our pediatrician to establish what is the final plan and to follow up how the patient is doing. It is important to have some considerations when you are taking care of patients that have mental problems, or patients that are having any diagnosis or developmental delay, patients that are on the spectrum. So our office offers a sensory room that we want to see that video later. And we accommodate our patients. We try to, those little kids, we take care of them in our office, and if they need a blood work or something like that, we set up a separate appointment. We coordinate. The patient can be in our sensory room with music, try to relax the patient. We give them some options, and we do blood work at the office. Another service that we provide is a telemedicine appointment. When we have those kids that establish a relationship with the practice, they are already being seen for ADHD for years, and they are going college. Why they have to see somebody else? So we accommodate those patients, and we set up follow-up appointments by telemedicine every 1, 2, or 3 months, depending on what they need. And they also see the provider in our office when they are in town for vacation or for summer break. So we have a policy that we see them 3 or 4 times in office, and also we follow up by telemedicine appointments. One of our very important services in-house is that we have psychologists that support our child and do counseling through CBT with the families and with the patients. Very important that we have that feedback with our psychologists. If we need the psychologist to see a patient for an emergency, she comes to the office and extra hours. And it's very important that when she's doing therapy and she feels like the patient, it's time for a patient to take medication, or it's time to get the patient reevaluated, she communicates with providers, and we set up that kind of follow-up. So it's an in-house service, and we provide this for all our kids. It is also very important for our department that we interact with the schools, and we collaborate with the school district and our schools in the area to be in the same page. We provide, our social worker can contact the school. We can talk with the ESC coordinator if they need something else. We provide the letters for schools so they can understand what's going on with the patient and how we're helping them. The most important part is that we do this to help the patient to get the services that they need in a school too. Our sensory room is in one of our 3 offices in the Public Garden location. This is a space that we design for our patients who are getting overwhelmed, or that need to be more relaxed, or patients that need that kind of sensory stimulation. So you're gonna see a video about how our sensory room is, and I hope you enjoy it. To finish, I'm going to talk a little bit about how we do this approach. It is important that everybody understand that not all the services can be provided in the practice office. So it is important to coordinate all the services that they need. As I say, we provide accommodation, we provide a psychologist in-house, we provide a social worker who work with the families, but we also help those families to get the service that they need outside. Physical therapy, occupational therapy, have lists of the providers in the area. Try to communicate with the schools. Communicate with the universities, the program, the research that have program for those kids with special needs is very important. So I hope you enjoy how you can integrate behavioral health in your pediatric office.
Thank you, Paola. Just to let everyone know, that sensory room, which is just an incredible piece of our office and our practice now, was developed and put together by Paola. And I really want to, again, thank her and appreciate what she has done. And it may have been hard just from that brief clipping to understand, but it comes from a place of understanding that, you know, if we need to get on the floor with the child, if we need to be at eye level, wherever it is, that room affords a lot of opportunities. We are able to play music if a child likes a particular type of music, the lights, as you can see. So again, I think it's really added quite a bit to our experience for our patients. So let me just talk about what we do specifically here at Pediatric Partners. We actually, and again, this is over time, and I would not expect those who are not comfortable with the multitude of diagnoses that we see in developmental concerns or in psychological issues to jump into everything at once, and nor should you. But over a period of time, as you talk and are more comfortable and talk with patients, you start developing that experience, that expertise, reading, looking, and the most important thing, the way you're going to learn is by talking to your patients, to your families, getting their feedback, remembering that when you talk to a family and to a child or an adolescent, young adult, is expressing the acknowledging to the patient that although the mother is sitting there or the father is sitting there giving all their opinion, their objective insight, at the end of the day, no one can tell the patient how he or she feels. And giving that, just that bit of power, that bit of choice to that patient goes a long way in your being able to communicate. And you will then start seeing, and being able to handle a lot of these various different disorders. And what I want to point out here clearly is that if the first slide over here shows comparison our behavioral health patients, our behavioral health patient visits compared to our general pediatrics. And at this point, it represents almost 20% of our total visits. And again, I'm not going to get into too much. This is probably another whole different discussion. But as we see in general peds and in general medicine, what's happening to healthcare, we're losing a lot of business every day to urgent cares, to emergency rooms, to telemedicine. Not telemedicine that Paola referred to that you do from your own patient-centered medical home, but to outside agencies. So the one piece that no one's going to take away, at least for a long time, is behavioral health. So it's important, it will help grow your business. And I think that's an important piece to recognize. And this slide over here just shows, if we divide in general terms, the percentage of behavioral health patients that have a developmental diagnosis is 17%, 83% is psychological. So again, I don't expect people to be able to immediately start with being able to manage and treat all these various different diagnoses, but we do in our practice, and again, it can be a goal, if you so choose, to go there. Okay. Again, just showing you, this is again our experience in our practice over the last 4 years, that you can see that the percentage of visits for ADHD has gone from a little bit above 8% up to 10% of all patient visits, and then for anxiety it's gone from 4% now to about 6.5%. Depression we went from somewhere around 1%, 1.5% to about 1.5% of all visits. again, in the number of children that we are seeing who are on the spectrum with diagnosis of ASD is climbing and continues to climb. And it's not that I would say that we are making more diagnoses, but it's because patients are recognizing us in the community as experts in the field of autism, in the field of anxiety and depression for their children. So we get a lot of referrals from the community. We actually have quite a few patients that come to see us just for these, to approach and manage these diagnoses, and yet they still manage their general peds at another pediatric office. So again, it's a way to develop and grow your practice. Again, just a quick interest slide. Most of our patients, about 2/3 of them, have a single diagnosis, but you can see that there are another 30% that have multiple diagnoses. And again, nothing surprising. We see that always in mental health, that there's a lot of comorbidity and coexisting diagnoses. Just real quickly, we've developed a medication management agreement. I think it's important, especially when you're dealing with controlled substances, the ADHD stimulants, but also for all your psychotropics, whether it is an SSRI, atypical antipsychotic, or an anti-epileptic drug that you're using to manage medications, that patients understand your guidelines, because like so many things with mental health, often the families, the parents are not all that much different than their kids. And so you need to establish guidelines so there's recognition and that they respect you as a professional, so that they know they need to come in, that they're not going to just get a refill over the telephone. So I think all that's important, making sure you work out a good no-show policy, billing and coding, and certainly we can go into detail if anybody has questions after the talk. Again, what are the benefits? Again, we've talked about it, but it's increasing patient satisfaction. It is improving physician satisfaction. At one point, we did our own internal survey of our own physicians, and what the results came back is that most of them felt good, those that started engaging in managing mental health, because it's intellectually stimulating. And to be honest, and maybe this is somebody who is been practicing for over 30 years, but we've all seen snotty noses and dealing with that, and certainly, as we know, that almost anybody can take care of that, but not anyone and not everyone can take care of something that is challenging, such as mental health. So when you're able to get the feedback, the positive reward from patients, appreciating what you're doing for them, that builds personal satisfaction. And in this era that we're seeing so much physician burnout, I think it's really important that as a practice, as a group of pediatricians, that you're able to start doing something that constantly keeps you challenged and keeps you wanting to practice and wanting to learn new skills. Again, it's important from my perspective, advocacy, being able to not only advocate for the child in your office, but to advocate for them in the school district, in the community, at the state, national levels. Because again, as we all know, no one is speaking out for children except for parents and for pediatricians. This was a study that actually our psychologist did, and again, it was part of her doctorate thesis that she did a number of years ago, but this was surveying patients that were receiving within our office psychological social services and the high incidence of satisfaction from patients. I'm not going to spend much time on this, but it's clear to note that there are lots of people are starting to look at on a national, state level, what can we do to help improve access to mental health. So there are a lot of research opportunities. Another opportunity for you in your practice, because certainly it's another means of a funding resource, and so that's important to take note of. One of the things that we're very proud of here at Pediatric Partners is that we became the first practice of any sort in the state of Florida, I think one of the first 30 or 40 practices nationally to receive NCQA's recognition, distinction in behavioral health integration within the patient-centered medical home. So yes, first you have to become a patient-centered medical home, but there is then that secondary step to become recognized as a practice that is delivering care to our patients, that integrates mental health. We be able to demonstrate better outcomes, and certainly is another way for you to stand out amongst the community, amongst patients, and also build your practice. So I sort of mentioned this when we first started the talk. You know, it's almost like a fear that a lot of my colleagues have about, can we do this? Can you do this? Or were you trained to do it? So, you know, most of us, and I think even to this day, I think some residency programs are certainly trying to increase the amount of mental health, behavioral health, developmental health that is received. But as you all know, unfortunately, most of the training is still geared to acute care, ICU care. And so most pediatricians coming out of residencies don't feel like they have the skill set, the training, the experience. But you can. I mean, that's your job as a physician, to start training yourself. The story I'd like to give is back in the 80s when I first started practicing. I was on the executive medical staff of one of the local hospitals, and it was the whole the whole practice of laparoscopic surgery was just brand new. And I know it's hard, some of you were not even born at that point, but it was not that many years ago in reality that surgeons who were trained in their residency fellowships didn't learn how to do laparoscopic surgery. And our job as medical executive board members was to determine how to credential these surgeons. And what they did was they went away for a 2-day weekend, 3-day weekend, and they learned laparoscopic surgery. And so from my perspective, if a surgeon can learn laparoscopic surgery in a 2-day course, you can learn how to manage mental health patients. There are more and more programs out there. There's a program called REACH that trains, I think it's a 3-day workshop that trains you to how to recognize mental health, how to manage it. And there are many other resources out there, but certainly it's something that you need to, as physicians, we're always growing. Remembering, you know, we were taught how to prescribe medication. We look at both the risk, we look at the benefits, interaction, and there's always new medications, whether there's a new antibiotic, a new heart medicine, but you have to learn those things. So this is really in the same perspective as those, and it is something that you can do. Go slow, go and take your time. Start when you start prescribing. You know, you don't have to, just prescribe in small amounts. Have the patient come back frequently. That's how you're going to learn. Get that direct feedback from the patient. Again, I just think one of my heroes in medicine is Patch Adams, especially the Robin Williams character. I mean, this is the actual Patch Williams. But we, as clowns, need to elevate the possible, and we need to relieve suffering. That is our job. That is what we swore in our Hippocratic Oath to do, to take care of patients. It's something that we all need to do. So when we talk about the rewards of medicine, taking care of patients, it's a very special child of our practice who has grown and has changed so much from a developmental perspective. And it is rewarding. It is self-satisfying as a pediatrician to be able to watch children with special needs grow, develop, and become more integrated into their family life, into their school, into their community. So let me stop there and see who may have any questions. Thank you again for joining us on this journey. If anybody has questions, wants to reach out to me at any time, please do so. And I encourage you once again to get involved, engaged with your patients in caring for them. Thank you.